Welcome to QD Clinic. Hi, I'm Jack Cush with RheumNow. QD Clinic is brought to you by RheumNow.live, January 27, 28. It's not too late to register. This is a meeting that is timely, relevant, and engaging. We answer your questions, all your questions at RheumNow.live. So today's case is a 33-year-old woman who's on methotrexate for rheumatoid arthritis. She's been doing good. She's been taking methotrexate for the last 2 years, has her psoriatic arthritis under good control. She's taking a non-steroidal drug as her only other therapy for occasional aches or stiffness. She is 33 and she wants to get pregnant. And the question is, what do I do with my methotrexate and my naproxen? How long do I have to be on or off of those drugs, or specifically methotrexate, and I'm worried that I may flare? So what is your advice to the patient? There's a few things that are certain here. Yes, you have to be off methotrexate to conceive. The question is, how long? The formal answer that you'll get from 99% of everyone out there is that you need to be off methotrexate for 3 months. The answer you'll get from me, the 1%er, is you have to be off for 1 month. I was on the ACR Reproductive Guidelines Committee, and when I brought up the 1 month to all the other committee members, I got voted down and shouted down, even though I had the only evidence that would support this issue. The only evidence actually comes from the manufacturer of methotrexate, back then known as Rheumatrex. It was the company called Warner Lambert. If you go and look at the package insert for Rheumatrex or methotrexate, and by the way, you can look this up at a website called Daily Med. It's called Daily Med, and it might be dailymed.gov, but search for Daily Med. Daily Med will give you the package insert of every drug ever made anywhere. And when you go in there, you'll find out there's 25 different generics of methotrexate, but find the original one by Warner Lambert and Rheumatrex. And when you look under, guidance regarding pregnancy, the actual wording is that you have to be off of methotrexate for one ovulatory cycle, meaning for 1 month. Again, that was based on animal data, and we don't know what else, but there are really no other sources other than the preponderance of opinion from everybody in OB and rheumatology that says 3 months. This issue was brought to my attention by Mike Weinblatt, who was probably involved in the original trials for methotrexate. So I do recommend that patients be off for 3 months because that's the prevailing opinion that you would get in a court of law. It's not the most authoritative one, so I'm okay with someone who's been off of the drug for a month or even 6 weeks. That's what I would recommend, but that's me. I'm not saying you should do that. So 3 months would be the answer. You can stay on the non-steroidal up until week 32, and then you should be off of all non-steroidal agents because that would lead to a lot of complications, including premature closure of the ductus arteriosus. So the other issue is what non-steroidal is safe during pregnancy. I think there's better evidence about the safety of the non-selective non-steroidals as opposed to COX-2s. There's some negative data about COX-2s in pregnancy that I think is, I'm not 100% certain, but nonetheless, I would avoid COX-2s if I could. Pain management can be done with either acetaminophen or prednisone if necessary, and I don't like prednisone. So that's really, I guess, the first question. The next question is, what would they take during pregnancy? As I told you, if they needed more than methotrexate, I'm entirely comfortable with patients being on every biologic we have, especially the TNF inhibitors throughout the pregnancy and continuing throughout delivery. And that would be especially so for certolizumab. But I would also use etanercept as my next best choice, and even adalimumab, and stop either adalimumab or infliximab with about 8 to 12 weeks left in the pregnancy because the antibody may cross over the placenta. That's sort of the second issue. Again, the mother's health and RA activity needs to be your first priority. The idea that you may say to your patients, don't worry, we can stop your drugs because everybody with RA goes into remission is frankly wrong. Up to half of patients with RA who stop all their drugs and become pregnant will continue activity or get worse. The number who will actually get better is probably only a third. A third will probably skate along as they are. But again, optimal disease control gives you the best chance at a healthy offspring. And that should be, so whether you get there by staying on a TNF inhibitor or an IL-6 inhibitor, again, the only drugs I haven't used much in pregnancy would be JAK inhibitors. I've never used rituximab because it's too long a duration of effect. But all the other drugs, abatacept, IL-6 inhibitors, TNF inhibitors, I'm happy to use. And then lastly, what should you do postpartum? I think the patient can stay postpartum immediately on the same therapies they were on at the time of delivery. They're not likely to flare until they stop breastfeeding. That's been my rule. So I tend to want them to breastfeed for at least 6 weeks, and then I'm starting to advise them to go back on their therapy, noting that they can take biologic agents, even though that maybe in breast milk it's not going to get to the child, it's not going to do the child any harm. Anyway, this answers the question of how long do I have to be off of methotrexate if I wish to get pregnant. We'll see you at New RheumNow Live. It's coming in 2 weeks.